This
Eric just
conference
mentioned,
will now be recorded.
it's recording, so if you have any kind of a problem or disagreement with that, we announced that we'll be recording the second and fourth sessions of the month. So you can either choose to attend on the non-recorded sessions and watch the other ones at your leisure, or, as I said, change your name, turn off your camera if you're so inclined. First, we would like to thank our sponsors that help make this ANCAN immunization run and be what it is. That would be Bayer, Novartis, Johnson & Johnson, Myriad, Telix, and Blue Earth Diagnostics. As you know, what we try to do is everybody on this call should have not received or been receiving any treatment for prostate cancer. If you have been treated or in the process of getting treated, we have other groups that may fit your needs better. You can certainly stick around and listen, but again, this is for the active surveillance group. So I'm going to take roll call, ask if every individual that I have listed here, if they need any time, and especially if you're new to this meeting, if it's the first meeting you're joining, please let me know that. I don't think so from the names I recognize most, but sometimes they sneak up on me. So Ignacio, do you need any time this evening?
I just have a super quick question, but only if time allows. It's not important, so only if time allows. Thank you.
Okay. Tom in Virginia, do you have any questions, sir?
No, not tonight. Thanks.
All righty. Alan, do you need any time?
Not really. I got some accidental test results, which are positive, I guess, but nothing really.
Okay. Well, just, if it looks like perhaps we'll get done maybe on time around 9:30 or so, or even before, be sure to just raise your hand and let us know what kind of, especially if they're considered to be good. We always like to hear good news. Andre, do you need any time?
Just to report of my last week follow-up.
Okay. Chris, out in California, sunny California, I hope. Do you need any time?
Yeah, I could use a couple minutes if time allows.
All righty. Mike Williams, the traveling man, do you need any time?
I'll be mostly listening, but I might have some comments somewhere.
Okay, we always appreciate your comments, that's for sure. Jay from Van Nuys, do you need any time?
Just maybe a minute, just to update on my visit with my second opinion with the urologic oncologist at UCLA today.
Good, excellent. Derek, do you need any time, sir?
Well, thank you, Gary.
Okay. And Mr. Wood, Bill, you need any time? Always good to see you, buddy.
Good to see you. No, thanks. I'm okay, fine.
All right. And BJ, AKA John, do you need any time?
I'm going to be in and out of this, but I did have something to talk about my situation. So if there's time, yes, thank you.
Okay. Paul, do you need any time? Paul? Okay, we know it's unlocked. Ray, do you need any time? Ray? Couldn't hear. Do you need any time?
Bijan, I think, asked me if I would talk about just what I was doing nutritionally. So if the group wants to hear, I can talk about that. Other than that, I'm just going to listen. So.
Okay.
Are you new, Ray?
Yeah. Last week was my first week.
Okay.
Mike Wynn, haven't seen you in a little while. Good to see you. Do you need any time?
No, thank you, sir. Appreciate it.
All right. Yeah, good to see you. And somebody else might have snuck in too.
Okay.
Caller number 2.
I don't even show a caller number 2, but is there a caller number 2? Has anybody out there that I haven't addressed yet besides Paul?
Hi, Gary. It's Paul. I'm sorry, man. I couldn't get my mic to go on. But no, I'm good. I'm just listening in.
Okay. All right. So, okay, we don't have anybody, first timers or AKA newbies, I guess, as we're calling them now, on board. So we've got plenty of time for everybody to, talk about the results or good news, maybe some nutrition from Ray. So, Ignacio, you go first. You just have to turn on your mic.
Where did he go? Oh, there he is.
Here he is. Ignacio, we can't hear you.
Sorry about that. I lost the window that I was on. Sorry about that. I am going to be super quick. The question that I have is this: is that I have so I'm after everybody's opinion. I have an MRI scheduled for June 23rd, so it's a couple months out. Now, in California, the Artera test is now approved and has been for about 4, 5, or 6 months. Now, I have done the Oncotype test, and I've also done the Decipher test. Both of those came out low. My question is, would you recommend that I also do the Artera, or is it going to be overkill? And if the answer is yes, that I should do it, should I do it prior to the MRI or after, or does it even matter? And
Okay. Well,
I can talk to that a little bit because I've had both Decipher and Artera, and they both look at different genetics of your biopsy slides.
Mhm.
So if you want a new data point to consider, it doesn't hurt.
Okay.
If you're the kind of person that's like, it's too much information, I don't need to know that much, then don't do it. If you like
No,
more data points.
I'm the opposite. I want as many data points as possible. Especially since I'm trying to safely avoid having any kind of treatment. Okay. Would you happen to recall the process? Do I call my urologist who has my samples and he orders it? And okay.
Yeah, the doctor will order it and coordinate with whatever lab that has your slides.
Oh, okay.
If they're digital, then they'll just send the file. If it's
Oh,
not
okay.
been scanned yet, then I think Artera will scan them and then in Jacksonville, and then send them back to the appropriate lab for storage.
All right. Sounds
now,
good.
Ignacio, we're talking
Yes.
two different things, though, right? We're talking an upcoming MRI, and Artera needs your slides, correct, from your last biopsy.
I mentioned the MRI, just to paint the whole picture. That MRI is going to be with Dr. Carroll at UCSF, and he suggested that I do that, and I have a full confidence and trust.
Oh, absolutely. Real quickly, tell me what your latest Gleason is. Do you have some 7? Do you have 3 plus 3? What I can go back in my notes, but just
Sure.
fill us in on what's been the diagnosis to this point as far as PIRADS and your Gleason scores.
Sure. Okay. So I've had a couple of biopsies. The last one was last May, and that turned out with 7 cores positive out of 14, and 2 of those cores had a 3+4, but not much, like 5% or so. I also had an MRI prior to the biopsy, so the biopsy was targeted. The MRI showed a PIRADS 4 and a PIRADS 5, and that freaked me out, to be honest. However, when they targeted the lesions, the pyrad 4 and 5, those, came the Pirates 4 actually it came out good, and the Pirates 5 came back with 3+4, but the 4 was only like 5%. My urologist recommended that I have treatment, so I actually had it scheduled for the end of September.
Oh yeah, now I remember you went out to the conference and
Right.
they changed the about face and yeah, okay. See, now it's all coming back to me now. Me and Celine Dion. Okay.
That's
So
amazing. Yes.
I do remember the story. So, and of course it's going with Dr. Carroll, one of the Center of Excellence good guys.
So
yeah,
what?
if you're the kind of guy that wants, that you really want to know, I think you answered your own question, as far as what you thought that you might do at this particular juncture in your
Right.
journey. And
Right.
as Eric said, it sounds like that's what you want to do. If you're a data guy, you want more data points, that's the way to go, especially if Carol
Yeah.
recommends.
Right. It's basically just to ensure that it's not overkill, right? Because I have the promise results, the decipher results, the oncotype results. All of those are low, which is great, right? That offers me hope.
Yeah.
However, there's something going on because the biopsies, they come back positive. The MRI shows a Pirates 4 and a Pirates 5. So it's kind of like a dichotomy in a sense, right? The genomics, those show up good, but the actual samples from the prostate are
How has
not
your
as
PSA trend
All
been?
right. Well, Phil's got his hand up. Maybe he's got something to add. Go ahead, Phil.
Yeah, no, I mean the only thing I have to say is just the Pirates 4 and 5 are they are not they're I guess they're indicators of a concern, but the problem is that because the numbers are high, it scares the shit out of you. But
I could not have said it better. You captured what I went through perfectly. I mean, it scared the crap out of me. Yes.
Yeah, no, I agree. You know what I tell you, I think I'm gonna try and speak to Howard. I mean, we really ought to have sort of like better some better data on PIRADS 4 and 5, so that I mean, the whole idea, like, yes, you're concerned, but it ought not to put the fear of God into you. I mean, and I guess that's what I'm hoping Howard can get us some good information on that, and
Sure.
maybe everybody will feel like a little bit better, because I mean, you're not the first person who's had those kind of high readings that upon examination have really not proved out. So you've got like you get all anxious and you're all and
Yes.
boy, it wasn't quite what and I guess everybody could say, oh, don't worry until you get the results. Don't worry. It's easier to say don't worry than
Right. I appreciate the comment. I will add, the MRI also showed no ECE, no extracapillary extension, and I also had a PSMA PET scan,
Oh, good.
and that came back clean. So
Terrific.
so overall, I'm optimistic and hopeful that I can remain in this group, right?
I agree. I agree.
Well,
I
for
hope you
every-
can.
The active
It would,
surveillance.
it would certainly appear that
Yeah.
you hopefully will be in this group for a long time.
Yeah.
Well,
And
thank
that's
you.
a good point, Phil, because I wonder, we talk about PIRADS from basically, no one says, PIRADS 1 to 5. I wonder what's the determining factor to make it from a 3 to a 5. Is it like 1 centimeter on a lesion? Is it 2 centimeters?
I don't know. You know what? I'm gonna write Howard. I'm gonna ask Howard whether I mean, he's got so many contacts that, it's something that I think, A, it'll give him an excuse to write something, and B, we'll find out some good information.
Well, I don't think Howard ever needs an excuse to write. That's for damn sure. That boy don't need no excuse to write. That's for sure. But that's a good idea, because I wonder, what differentiate? Yeah, what's the difference between a 3 and a 4? How are we talking? It's just like if somebody's diagnosed with a 3+4, and it's 7%, versus 5, that kind of thing.
Yeah,
Alan's got his hand up. What do you want to add, Alan?
Just quick, and you may be aware, but Decipher and Promise are two completely different things. Promise is looking at if you're predisposed because of a genetic mutation. I don't know the test you're talking about doing now, but just for the group in general to make sure that you understand they're two very different tests.
My understanding is that Artera is basically what when you get a reading and they give you a Gleason score, it's a similar thing, but it's done with AI, so it's more systematic and programmatic in that way.
But just so you understand it, it is not an overlap of Promise, because Promise is only looking at if you had a gene mutation.
Right. Well. Again, I tried to paint, the whole situation, and that is that all the tests I've done, Decipher, Promise, Oncotype, they all came back low.
Very good.
Oh, and Eric, to answer the questions you had, my PSA has stayed steady now for almost 3 years between a low of 3.4 and a high of 5.1.
Great.
The latest was 4.8 about 3 months ago.
Good.
Well, you're right where you want to be. I mean, I don't think any of us would argue that statement.
All right,
everything that you've had, everything that's going on, and everything that you're doing, all the right things, and you're getting a whole lot of information. I have never done half of what you've done, because I'm not one of them data guys. A PIRADS 2 with no lesions is good for me. So just let that go.
All right, thank you.
That's me. Everybody is different and handles everything different.
All right.
Derek had his hand up. Derek?
Yeah, I just want to mention that I've been with PIRADS 4 with lesions for the last 3 years. Did 2 biopsies, and now I'm kind of saying, well, maybe I shouldn't have done that second one. But the biopsies came back negative both times. Oh. And is the PIRADS score not a visual interpretation of somebody's eyeball?
Yeah.
Right. So everybody's eyeball is a little different in their interpretation. So bear that in mind as well.
Yeah, but I watched the videos with Dr. Scholl's, PCRI, and the claim is that 80% or so of PIRADS 5 is not good. So as Phil said earlier, it scared the crap out of me at the time.
And then the other thing I'll mention is last year my PSA was 5.3, and then this year at the same time the PSA came down to 4.1.
Yeah. All right. Thank you all for your time. I appreciate it.
All righty. No problem. Anybody else have anything for?
Yeah, the PIRAD 5 just means there's probably cancer there, but you already know that because you've had a biopsy. So if you look at the chart I put in the chat, is a very high chance there's probably a cancer there. What grade is it? They don't know until they biopsy it.
And of course, the key word there is clinically significant. What page is that on, and who wrote that book, and who's looking at it when you say clinically significant?
Right. In my case, it was a 3+4, and I actually showed it in person to Dr. Scholl's at PCRI conference, and he basically said, "I'm fine."
Yeah.
So
Well, that's good. That's real
that's
good.
uh,
I'd go with
heavy
that.
vote of confidence.
I'd stick with that.
Yeah.
Once you have a 5 and it's been targeted and given a Gleason score, that's what you hang your hat on.
Yeah.
Yeah.
Yeah, for
Yep.
sure.
Thank you.
You're welcome.
Okay. You're welcome. Andres, you got a report on an update?
Yes, just quickly. Last week I reported that I was having some kind of problems in my groin area after the biopsy, and it had been like a month. So the next day I had the visit to the urologist, and well, he said that if it was a sepsis or an infection, I would have died by now. So he said, it's not going to be that. It's not. It's probably a stress combined with prostatitis that maybe is still inflamed from the biopsy, and he says probably the stress you're having, or the nervousness you're having, and with the recent diagnosis and prostatitis. So he just kind of prescribed some kind of a medicine for prostatitis, which I forgot to buy, or I couldn't go to the pharmacy to buy in a couple of days. So by the time two days went by, all this kind of discomfort kind of went away. So that's the end of the story.
Well, that's a good thing. Now, I take it you had a transrectal biopsy?
Yes.
Yeah. Okay. Well,
Yeah.
this is
And I'm still
one
kind
of
of
the
relieved.
reasons why we really preach is not a good word. Why we really try to stress that people have transperineal biopsies, because the chance of getting sepsis, which you didn't have, and it's really nice of the guy to say, well, you don't have that because you'd be dead by now, but that's a really good bedside manner. But anyway, really, anyway, I guess they went ahead and did gave you antibiotics. Did they give you some before your biopsy? Maybe a day before, day of, day
They
after?
gave no penicillin, one injection of penicillin right at the end of the biopsy. Right at the end, that was it.
Normally, they prescribe an oral antibiotic the day before, the day of, and the day after, and that's what and it's pretty heavy duty stuff, because they're trying to head off sepsis at the pass. And of course, there's a very slim amount of people, a low number, that die from sepsis from a biopsy. But guess what? You don't want to be that guy. I don't give a shit if the number's low. I don't want to be that guy.
Right, there you go.
I don't give a shit.
Also
well, it's
very
1%.
expensive.
I don't want to be that 1%. And
Super expensive to fight too.
transperineal takes that completely away. So, that's why there's such a big, such an item of discussion, and among the professionals, because it's much easier. They make money quicker and easier doing a transrectal in an office than in a operating space. So, and there's other facets to that argument. But you most probably just had a little bout with prostatitis, some kind of, as you said, by the time you got around to buying the medicine, you were feeling a lot better to start with. So luckily, no big deal. And right now you're feeling rather well. You're doing all right?
Back to normal?
Yes.
Very good.
Yes, I'm good.
Very good.
Yay!
That's good
Stay
news, but
healthy.
we're going to keep you in the archives as far as, transrectal having, it's having a minor, let's put it down as a minor difficulty, because that's good. We'll keep it in the minor column, because it certainly could have been worse.
Have you gotten your results back yet from the biopsy?
Me?
Yes, you.
Oh, no, my biopsy was in March. That was so that's
sorry.
why I was concerned, because it had been a month and a half, and I'm still having this kind of discomfort, and that's what I'm more concerned. I say, it's been a long time already, and even though I'm still finding some blood, still, but people say it might last for 2 months. But the discomfort was something that was bothering me. I couldn't sleep. I woke up in the middle of the night.
What was
And
your
so now
last
I'm much better
PSA?
now. The PSA was 3.5, and the biopsy, the Gleason was 3 plus 3, and
Excellent.
3 out of 10. Yeah. Hmm.
Okay.
Yeah.
Well, we've got some hands up. Jose?
Hi, sorry I'm late. Andres, you had a urine test, right? The same time,
Yes.
and
Hmm.
that was negative?
It was negative. Yes, it
Okay,
was
all
all
right.
negative. Yes.
So that's
Hmm.
good. Okay.
Thank you, Jose.
Yep.
Negative
And
for
Ray,
infection.
you got a question?
Yeah, I was just going to ask them if before they did the biopsy, did they test your like your stools for E. coli or any type of bacteria like that? Because they didn't do that because they did that with
No.
me, and there were there's bacteria that showed up, so there are other bacterial infections besides sepsis that you could have had too. So
That's
No.
interesting.
No, I had.
I've never heard of testing of stool before before a
yeah, or they swabbed my rectum. I'm trying to remember, but I remember because it did come back as I remember I think I had E. coli and one other bacteria showed up there. So
Did they delay the biopsy because of that?
no, they gave me a hydro uh, um, a fluoroquinolone antibiotic,
Yeah.
levofloxacin, and they didn't give me the black box warning, and I developed tendonitis almost immediately and took the full course and couldn't walk for about a month almost, and had to redo my whole workout routine because I had to worry about snapping a tendon. So, but no, I didn't have any infection. That's what they gave me. They gave me for it, but I'm not wanting to do it because, well, A, because I can't have a fluoroquinolone antibiotic, and B, just the risk of infection too. It's not doesn't thrill me. So
Another good plug for the transperineal approach for
Exactly.
sure.
yeah,
Yeah, that's discomfort, sepsis, and you getting some kind of adverse reaction to an antibiotic.
and
Which you should.
on the transperineal, does it matter like where the tumor is as far as being able to reach it for a biopsy, or they can reach anywhere in the prostate just as they can through a transrectal?
Again,
I remember it was,
area,
sorry.
another big area of discussion. One saying they can do so and so with the transrectal versus the transperineal, and on the other side, transperineal versus transrectal. But I do believe perhaps there's one side that is favorable on either procedure, but they're going to poke wherever they want, whether they go with transperineal, transrectal. I had what they called a precision point transperineal, which they only poke you once, and then they can move the needle all around where they want to go, and that's been refined now. There's a new method. Um, it's just, of course, it's on the outside. The needle goes through it, and if you could picture, I don't know, just little slots where you could move something and you move it lower and you lock it in on the right, and then you take it out, move it up, and move it up a notch. It's something like that where they can even get more mobility with the needle now. That's something brand new. That's better than precision point. So
I seem
no,
to remember transperineal had better reach of the apex or something.
Yeah.
that sounds right. That sounds right. So I mean, we here at ANCAN preach nothing but transperineal. If somebody's headed for a transrectal, we try to do everything possible. Of course, we're not doctors. We're not making medical decisions for you, and you have to be your own advocate, and you have to feel good about what you're doing. You know, if you're a guy that wants to do 18 different kinds of tests, we tell you to go do it.
Yeah.
The same with if if you've got somebody that doesn't do transperineal, and you feel comfortable with transrectal, versus even listening to some of the not so favorable characteristics, we're certainly not going to say anything, but we just like we believe in second and third opinions without unequivocally.
Okay.
That goes without saying. The minute somebody comes on here and they're a new guy, it's like, did you get your pathology, a second opinion, perhaps an MRI second opinion? And plus, we have all that information now. Somebody needs, needs to know where to go to get a second opinion for one of the diagnostic processes, we can set you up, or we can find you a doctor or a center of excellence.
Right.
And Ken is really, really good with that.
Does that answer your question? Ray, does that answer your question?
Yes, yes, yes.
Awesome.
Okay.
Who's next?
All right. Chris
Al?
out in California, what do you got?
All right, thanks, guys. Last night I had an MRI, and surprisingly, I got my results already. It was my second MRI, and I guess the first thing I'll say is thanks to you guys, I ended up getting the MRI on a 3 Tesla. I had to drive about an hour and a half. I had an appointment scheduled a couple of weeks ago for a 1.5 Tesla, and I asked my doc to change it. So I went down to Oakland and got the MRI last night. I was pleased to find out, you guys maybe know this, but the last time I did it about 2 years ago, they used the probe, the rectal probe, and it really was uncomfortable. So I don't know if any of you guys have experienced that, but with the 3 Tesla, he said they don't do that anymore. So I was quite relieved. I was pretty happy about that. So that was sweet. So my question, just real quick, the results. In my first MRI, I had 2 lesions. One was 1.4 centimeters and one was 1.2 centimeters. And I haven't talked to my doc yet, so some of these results, I'm not quite sure what they mean, and that's where one of my questions comes from. But the lesion number 1 has gone down in size to 1.1 centimeters from 1.4. And the second lesion went down from 1.2 centimeters to 0.5 centimeters. I'm a diet and lifestyle guy as well. When I found out I got diagnosed 3 years ago, I just went super hardcore. I believe that I've talked to a number of guys who believe that diet and lifestyle and also my spiritual practice could actually, help me along with regression. So I feel pretty good about that. And I'm going to be having another biopsy in June, so we'll learn some more. So my question comes from this time there was a third lesion. And the first 2 lesions were PIRAD 4. Both MRIs, they were PIRADS 4. So this lesion number 3 says, and I just want to know if this makes any sense to you. Ill-defined area of markedly hypointence T2 signal along the left transition zone near the prostate base, measuring approximately 9 millimeters, PIRADS 3. So that was, I'm not sure that I haven't had any biopsy on that area, so I don't know. At least, it wasn't cancerous before. So that's my question, if that makes any sense.
Yeah, it's like a fuzzy area on the MRI, and they're like, there's something there, but we're not quite sure.
Yeah, that's what it
They're
sounds
just putting it in their notes just to have to reference to on the next one.
Yeah.
Bill, you had something?
No, I think that's exactly what you said, Eric.
Okay.
Imprecision.
Yeah. It's like a shadow or fuzzy area, or the density of the prostate is just slightly off, and they're like, let's put that in the notes to keep an eye on, but it might be benign if they targeted it. They just don't know.
Yeah.
It's all guesswork on imagery.
It's like they didn't see it before, but they see it now, so they just note it because they don't know what they're looking at, but they're looking at something that wasn't there before. So
what's your PSA?
It can't be definitive.
My PSA has been really steady around 4.0.
Piece of cake.
Perfect. Keep doing what you're doing. Sounds good.
Sure. Anybody have any other questions for Chris?
Yeah, I wanted to mention that I had lesions show up one year, and then the next year that lesion was gone, and then a new one showed up somewhere else. So yes, they can come and go apparently.
Yeah, we've had people that, had Gleason scores and then they went away because they didn't, whatever was there was gone. So this is true.
Does that help you
Uh,
out?
Yeah.
I
Thanks.
was just
Thanks.
gonna, I was just
Go
gonna
ahead, Rick.
add that my one and only lesion was a PIRAD 3, same thing, ill-defined uh, border, and just because my PSA had jumped so much in a year, and that my urologist said we should do a biopsy, and that's what I did. So, but mine was a PIRAD 3, same thing, ill-defined, and said it was equivocal, wasn't sure. So just throw that in.
Yeah, thanks.
Hey, Chris, how long has it been since your last biopsy?
3 years.
Okay. Do you feel like you
And
need
that
another
was
one?
a random biopsy. They did my MRI after, which is interesting, but
Yeah, that's what I
that
had.
was 3 years ago. So
Do you feel like you need a biopsy, or do you want to?
yeah, I kind of feel like I waited, 3 years, and just the fact that it was random, I'd love to see him target these areas and find out. And then I probably wouldn't, if I'm still a 3+3, I probably wouldn't do one for quite some time, just based on as long as the PSA stays low.
Cool. Thank you. Up, Derek.
Have we ever talked about needle shedding during biopsies?
It's a possibility, but it's like super low,
Is it?
like less than 1%. Like it's hard to prove.
Right. Most doctors say it doesn't happen, but common sense or logic says other to me.
Yeah, I'm always like, do we want to poke the bear or not?
Right, right.
But it's hard to prove, and statistically, it doesn't look like it's an issue.
Okay,
What are
thank
we
you.
talking about? Needle what?
Needle
Needle tracking or shedding. After the puncture of the lesion, then there's going to be blood and there's going to be cells that come out with that needle. And where do those cells go and what happens to them if they are indeed cancerous?
Right. Jay?
How about that?
Jay, you have your hand up?
Yes, I'm sorry. I don't mean to try and cut in line, but I have to go if the group doesn't mind and with your approval. Can I just?
Yeah, you're next in line.
Oh,
Go right
okay.
ahead.
Sorry, they're calling me. So thank you. Didn't
Go
mean to
for
be
it.
impatient. Yes, so I did see a UCLA urologic oncologist today, Dr. Seigel in Westwood, and because they said get a second opinion, so I did. And I'm waiting for a second analysis of the biopsy at Johns Hopkins is doing it. My primary urologist was a private practice. I turned in the promise test, so I'm waiting for that. And today I mentioned the decipher, and so Dr. Seigel is going to send out for that. And then he said basically his opinion was, yeah, you're still kind of excuse me, sorry, I'm still lost my train of thought.
Candidate for AS?
Active surveillance. Yes,
Okay.
thank you. Thank you. You knew what I was going to say. But if I want to still look at radiology, I can see Dr. Keyshawn, which has been recommended from Rick and Mark and several people, just to discuss it. But I'm not making any decisions yet.
What is
That's
your Gleason score in PSA?
7, 3+4, grade. They put grade 2. They said.
How much for?
I'm sorry.
How much for did you have? What percentage?
I don't have that right in front of me, and I'm not real good at memorizing all that.
That's all right.
I remember
All
a
right.
number
Well,
was like
that's
60%,
okay.
and one of the
Still,
sizes was 7.8. But anyway,
but you're
You
still
can,
waiting for a second opinion from Hopkins on your slides, correct?
yes, sir.
All right. Well, that'll be critical in the decision making process to see if everybody's on the same page. Um, what does the PSA numbers look like in the past year or whatever?
Well, I made that mistake like a lot of us do. December, I had sex the day before, and I gave me a 6.9, but then we tested again in March, and it was 4.2.
Good.
So, and we did the MRI prior to the biopsy, and that was done in March, and
Yeah,
all
you're
that. So, and it was transurethral.
doing all the right things.
Yep, and if
All
your
right, I'm
PSA
learning
is
from you
down to
guys.
4, if your PSA is down to 4.2 and the 3+4, if that's a low volume that Hopkins agrees to, and you get the results of Decipher, you should be able to be with us for a long time, I hope.
That would be great.
That, you still got some more information to get back, so be sure and be here every Wednesday and join us and keep us posted. But wait till you get all the information and then see where you're at. And but I think you're right there with us, unless there's something that comes up in the second opinion of the slides.
Thank you. Great support from you guys. Really appreciate it. And my friend Derek, he supports me too. We're all friends.
That's what it's all about. We're all on
Yes,
the
sir.
same journey here.
Yeah, and I'm glad to share my information not only for myself, but it helps others.
Yes, it certainly does. Sharing is really important, and we certainly appreciate it. Anybody have anything else for Jay? He's got to run.
Thank you. Goodbye, gentlemen.
Okay.
Thanks, Jay.
Okay, he's out. I would like to welcome Joe. Joe, are you still with us? Mingrone?
Joe?
Oh, yeah. I'm still here.
Okay, I just wanted to say hello. And if we have a chance, do you have something to share?
No, I don't think anything new. I saw a BPH doctor that does HOLA last week, but I don't know if I reported that already. But anyway, if anybody's interested, I get to share the experience. But other than that, no.
And we can do that at the end.
What I've been reading, us guys, as we age and we're in this group, BPH is going to be a problem.
Let's go through our list before we...
Absolutely. We've got time. We're going to talk to BJ first. John?
He may have stepped away. He said he was going to be in and out, so...
Okay.
John, are you there? If not, we'll move on.
Okay, well, that's it for people that actually wanted time. Ray wanted to talk a little bit about nutrition, and now Joe might talk a little bit about HOLIP. So,
Alan, did you need time too?
Actually, could I ask a quick question? I saw my gastroenterologist because I'm having separate set of issues. And accidentally or prematurely, they did my PSA. What I was told by Dr. Eastham and Dr. McClure is not for 6 months after your biopsy. That before that, it would be premature to do PSA.
Yeah.
It was done at 3 months. It's twice my normal level or my base level. It came in at 2.6, but I've had 2 peaks of prostatitis, which have driven it to 4 and 5 when they've tested. I emailed Eastham immediately saying, I know you said not to do it, but it got done anyhow. What do you think? And his answer was basically, see me in July. Don't worry about it. I don't know if anybody else has had an experience of how soon after your biopsy do they do your PSA?
Usually it's a couple months, I think, for let it heal. Because it's been perforated, with a biopsy, so...
At least a couple.
The answer I got from somebody was that at 2.6 at 3 months, that actually means you're in really good shape, that your prostate is healing nicely.
Are you on any medication?
No.
Good. Yeah, that's a good number for having been perforated by a biopsy, in my opinion.
Because they had warned me that the biopsy could cause some prostatitis, which it did, and that flares a little bit. And they also think that the biopsy, and I did have transperineal, and I was put on a strong antibiotic even with transperineal. They think that caused some IBS, which I'm prone to IBS as well. So that's why I was at my gastro. And he also warned, I guess they used some type of probe even in a transperineal, and he said that may have also caused some of the IBS. So I'm busy trying to heal the IBS right now.
Was it a guided biopsy with a ultrasonic probe?
I guess it must have been. It was a guided because they had done the MRI and they were going after the PIRADS spot.
The ultrasound is the probe that goes in your rectum so they can target the lesion.
So they think that may have helped trigger some more IBS. Plus, he was also afraid that the Bactrim, I think is the name of the antibiotic. It's a very strong, surgical antibiotic, created what they call SIBO, which is an overgrowth of bad, whatever, in
Small
your gut.
intestinal bacterial overgrowth.
Exactly. So they're actually put me on yet. They've prescribed, but I haven't yet taken because it's calmed down, a medicine that would reverse that if necessary. Right now, they just have me on something to soothe the intestinal tract, and that seemed to have worked.
It's unusual they even gave you an antibiotic for transperineal.
They did. They gave me. I put me on it before and for a week after, and a shot during.
Gee.
Wow. They say why?
No, I think my guy was just playing very, very safe.
Yeah.
Interesting.
I mean, the whole idea with the transperineal is that you don't need antibiotics. I mean, there's a lot of discussion about, antibiotic overkill, and, the more you take, the more prone you are to certain antibiotics not being used. So that's why they generally don't use an antibiotic with the transperineal. But I guess, as you say, he was being, overcautious.
He did. At this point, Jose notes, I'm now a Dr. Eastham patient at MSK. So I'm with one of the top guys now.
Yeah.
Well, you might have some other health issues that kind of predetermine how they're going to treat what we kind of know as common for us may be uncommon for you, or vice versa. So maybe that's why he did prescribe an antibiotic. Because
it's also, they've warned me, even Dr. Easton said, part of the reason they want to keep me on AS as long as possible is if they treat, it will kick up the IBS really bad. If they can keep me on AS, they definitely want me on AS. And
well, you're in good hands there and with Eastham, so I'm sure he'll guide you in the right direction as long as you agree.
Right. Yeah, McClure said the exact same thing. So it was just odd when my blood test came back, and I was not expecting. In the test results, I looked down and go, "There's a PSA there. Why?" They must have one of them, either Eastham or McClure, had already put it on the chart, and when they did the other blood work, nobody stopped to say the gastro didn't order a PSA. They just went ahead and ran it.
Mm.
Were you properly prepped for a PSA in your mind?
Most probably. I had been at the gym earlier in the week, so that might have. But I wasn't riding a bike or anything like that.
Thank you.
So 2.6 is really good, though. So good job there.
Normally, when I'm in my best condition, last October I was 1.3.
Nice.
That's amazing.
I want those numbers.
Yeah, really.
I'm always won something except for the 2 times of the prostatitis, and then I went to 4 and 5. And I freaked out when they got the 5, and they retested me in 2 weeks, and I was down at 2.6 already, or 2.8 in a matter of a week.
Nice.
Anyway, thank you. I was just curious on how quickly they normally do a PSA after a biopsy.
I think 2 or 3 months is normal.
I had mentioned last time that there was a document that Jim Marshall had written on how to fail a PSA test. Did we ever find that in the arsenals?
I did find a Prostate Cancer Foundation thing about.
But not specifically Jim Marshall's.
No.
Got it.
There's actually, I think, some supplements that you're supposed to stay away from. I mean, I know the basic things you're supposed to not do, but I guess there's more than what I know, I guess.
Yes, there's medications. There's all kinds of things. Correct.
We'll have to scout that up.
Anybody else have anything for Alan?
I just have a question on this. How to fail a PSA, the medications, does that make your number rise or lower your number?
It depends on the medication.
Got it. Okay.
Lomax itself will cause it to rise.
Got it. Okay.
You'll have to try to get that and send it out in the newsletter or post it in the chat.
I'm gonna post the PCF thing about PSA just so you guys have it.
Okay.
Here
Anybody have any other questions for Alan? Okay. Ray, you wanted to talk a little bit about nutrition, I guess?
Yeah, what Bijan had asked me to discuss it. I don't even know if he's on, if people are just interested. He was interested in what I was doing because when I went full, I decided to do this dry January. And as long as I was doing the dry January, I decided to go full vegan. And when I get my PSA every 3 months, but they did, my general practitioner was doing a whole battery of blood tests. He said, "You want a PSA? I know your urologist does." I said, "Yeah, go ahead, do it." And it went down from 3.6 to 2.3. So I have no idea if that's just lucky or it was the full vegan. I kind of took an approach as food is medicine and made sure I had about 10 foods and things that were shown to be tumor suppressing, or there was some evidence of it. So I don't know if it was diet or some of the diet or just coincidental, but whatever it was, my PSA did go way down. So
whatever it is, it works for you, and that's what counts. Whether all of those things played a factor or didn't play a factor, perhaps one or two of them, perhaps none of them, because there's really no, scientifically, you can't say, well, I did this and this is the result, because there's so many other things going on in your life each and every day. But it's, if it works for you and it went down, that's definitely good for you. And of course, there's getting to be more and more proof data, scientific data. Of course, there was always data about exercise and cancer. Any kind of exercise is good when you have cancer, no matter what kind of cancer. And then, of course, about diet. And I guess the biggest consensus right now is the Mediterranean type diet, because more of us are going to die from heart disease than prostate cancer. That's for sure. That's a fact. That's a number. You can't run away from that. So everybody's trying to get everybody on a more heart healthy diet, which in turn would be good for somebody battling any type of cancer. But going to different ends of the spectrum, like full vegan or whatever, there really isn't a whole lot of hardcore scientific data, other than, like I say, the Mediterranean diet's been proven to be heart healthy through various clinical trials and so on and so forth. But if it works for you, that's the way to go. No doubt.
Alan, did you want to?
I also continued to lose weight too, which when I first was diagnosed, and I needed to lose weight because I was 5'7" at a high of 195, and I was carrying a fair amount of muscle, but still I was carrying a belly, and as they say, cancer likes a belly. So I'm now down to 171 and trying to get to 168. But so the vegan actually helped with the losing weight. I was kind of stuck at around 178 to 180. So that helped. And to what you said, the famous retailer John Wanamaker said, I know that 50% of my advertising is absolutely useless. I just don't know which 50%. So yeah, I don't know if it's the soy, if it's the sulforaphanes and the broccoli sprouts or whatever, but I'm just making sure I have it every day and seems to be working. So,
There you
or
go.
maybe it's total placebo. So I don't know. Hopefully,
Like I say, if it, but it's backed up by, lowering your PSA number too. So something you're doing, the weight loss, the diet, things that you may not even have control over, but at this point, it's working. So
yeah,
can't ask better than that.
no, it's
And we have a lot of guys that are in some form of vegan, and I don't know how many full vegans we've got, but I think everybody after a diagnosis gets a little bit more concerned about their diet, and rightfully so, because speaking for myself, it was not so good. So it does make you kind of, because when you hear the C word and the way these doctors lay it on you, it's almost that crap in your pants moment that we talked about earlier. What am I going to do? And hopefully, as I said, you have a far better chance of dying from heart disease than you do this disease at this stage where we are at. Not if we had metastatic disease. That's a whole different deal.
Does anybody have an opinion on fish? Because I've read a lot of literature, some saying fish somewhat beneficial as far as an anti-cancer, not with the heart, and then others, protein and everything may not be so good, or at least not that helpful. So is any opinion on fish as far as prostate cancer?
I do it. I do
Yeah, you
salmon
do
at
too.
least once or twice a week, or tuna fish, because high in omega 3s.
The omega-3s are very important.
Mm-hmm.
Hemp
I mean,
seeds are good, high in
I
omega.
have flaxseed every day,
Flax.
so I get the LAAs, the omega-3, the LAA from that. But I was eating a fair amount of fish before, and so that's why I was curious if. But I also heard there was a glutamine pathway too to cancer progression, and fish tends to have a fair amount of glutamine in its protein profile. So that's why I was wondering if there was any thoughts on, fish once, as you said, once or twice, or just, um, I guess I would prefer to have fish, but I'm just curious what people's thoughts on it were.
Well, I think that's kind of a personal thing
Yeah.
that everybody comes up with. I don't eat fish, so I'm out of luck. Never liked fish, so other than tuna fish, and now I read that every fish has got microplastics in them. That's
As
going to
well as
become a real
mercury.
that's going to
Mercury,
become a real
tuna's
big
the
problem.
mercury.
Mercury was the first thing, and now it's all about microscopic bits of plastic in the oceans that the fish are eating, that you're digesting when you eat fish. So they don't get you one way, to get you another. When you think you're doing something right, they ruin it.
Yeah.
I tell you, they ruin it on purpose.
Everything in moderation.
Exactly. Moderation. Thank you, Phil.
That's it. Don't eat the whole Coke bottle at one time, just a little bit. Okay, that'll work. All right. Anybody else have
Chris?
any opinions about diet? I mean, that's
Chris had something.
Oh, okay, Chris.
Well, yeah, as I mentioned earlier, I'm a pretty hardcore diet guy, so I'm like you, Ray. Um, I eat one piece of fish a week, uh, just to kind of splurge. And I think fish is fine. I'm with you, Gary. It's like whatever anybody wants to do. But fish is extremely high in methionine. And if you do a little research on methionine and prostate cancer, that's one of the things that I've really tried to stay away from, is try to keep as low a methionine diet as possible. So that's why I don't eat more fish. But
Mhm.
that's my comment.
I knew there was a reason I didn't like fish. Thank you, Chris. You made it quite apparent. Shrimp has never touched my lips. A lobster, a scallop, none of that stuff. Period. End of story. And that's why I just didn't know it. Thank you.
Chris, have you heard different levels or different fish have different levels of this thiamine?
Yeah, definitely. I probably couldn't find a link quick enough to send it to you, but if you Google methionine levels for food, there's a number of PDFs out there, and each fish has, by serving, it will have a different level of methionine in it. So there's some are better than others.
How do you spell that?
Chris, the first thing you have to do is tell me how to spell it because I could hardly say
Yeah, exactly.
You're gonna.
Yeah, methionine is METHIONINE, methionine, I believe. It's one of the amino acids, or
METHIONINE.
INE.
Okay. All right.
Methionine.
Yeah,
I'll put it in the chat.
All right. Thanks.
Yeah, I just looked it up. Yellowtail and salmon have some of the highest. Tuna actually has the lowest of the fish that they're quoting here. So
But yellowtail is tuna.
Yellowtail is tuna or red snapper? I thought
and I'm going to
yellowtail is a
Japan
red
and I'm
snapper.
going to eat sushi.
Yeah, I would. If I was going, I'd probably go off my vegan diet if I was going to Japan.
Again, moderation. All about moderation.
That's for sure. Okay.
So,
who has their hand up?
I did.
Okay. Ignacio just says.
Yeah.
Go ahead.
So I posted a link to a study, a published, a peer-reviewed study. So some good news and some bad news. Good news is that I too, when I got diagnosed in 2022, the first thing I did was to change my eating habits. What resulted from that is that I lost weight. I look, better, although my face might indicate otherwise. But I felt as a 58-year-old at the time, I felt maybe 45. I felt great. The bad news, though, is that the results of the study indicates that your eating habits do not have a much of an influence on prostate cancer.
Yeah, that basically has been the theory. I think, as I said, no one's come out with a prostate healthy diet.
Right.
And of course, what's the number one killer in men? Heart disease.
Heart disease.
So,
but I mean, if you eat a heart healthy diet, it has to be good for your prostate.
100%. And not only that, it goes beyond that, right? Because again, in my case, I went from like 192 pounds to 158 pounds.
Wow, that's great.
And wow. I feel a lot better. I'm almost 61 now, and I feel 45, 48.
Yeah.
So
and if you can combine exercise with a heart healthy diet, then right. you're doing yourself like a really great service.
Mm-hmm. Right.
Yeah, for sure. Chris, did you have a comment?
Yeah. So it's back to the diet thing. Just a kind of a confirmation bias. I tend to look for things that reinforce what I believe, like a lot of people do. But if you hang out listening to Stacy Loeb, who is a pretty solid person, and Matthew Cooperberg, who UCSF, he's pretty solid, and then Dr. Gio, who's got the prostate podcast. All three of those guys will quote studies that show it's not a double-blind, placebo kind of study, because you can't do that with foods. But there's a lot of research that points that food is certain diets are good for prostate cancer. So I know there's plenty of studies that show the opposite. But anyways, just want to throw that out there.
No, I don't think that they show the opposite. They just can't confirm in a positive way that,
Right.
but again, I mean, anybody who's following a sensible diet, vegan or otherwise,
Right.
is doing a great job for their heart, and that has to benefit prostate cancer.
Again, I think it's all about moderation, like
Yeah.
Eric said, and it has to be something that you don't fight every day, because it's got
Yeah.
a lot about to do with mental attitude. If you got up every day and you fight about what you're eating and you don't enjoy in what you're eating, guess what? You're a son of a bitch to be around, not a very pleasant person. You may not die of prostate cancer, but you're just one grumpy son of a bitch that nobody's gonna like. So you've got to find something. I'm not saying that you should go out and eat pizza every day, but
Right.
there's more to life than this disease, and it's a bigger. Let's all hope that that the disease is the lesser part of your life, not the larger part.
Yeah.
So I think a lot of that's got to do with, there's just certain things that people want to do or want to eat or places they want to go, and that all has to fit together. It all,
Yeah, we definitely want to minimize.
It's all got to fit together.
How to minimize stress. So
Yeah.
if you're stressed
Yeah.
about your diet, that's probably not a good idea.
And I'm sure a lot of people could fight. I mean, if I were now to try to be a vegan, I'd be one miserable son of a bitch. Period. End of story. That ain't gonna happen. I wouldn't want anybody to be around me because it's not gonna happen.
Right.
But just trying to be more conscious of what I'm eating and weight and so on and so forth. That's just a win-win, like Phil says. That's just a win-win in general, which has to be a win for you with the disease. So,
Make wise
Eric,
choices.
you have something else?
Yeah, I was going to say just another key component I feel to not just eating is the fasting piece of it all. Letting those meals space out, or getting enough hours of fasting, and or going through a fast every once in a while.
Yeah.
I just feel is very beneficial.
I do that. I do intermittent fasting. I don't eat till after 3 in the afternoon. So
There you go. And do you feel a benefit from that?
well, I've done it for before I was diagnosed with prostate cancer. So yeah, I do have I concentrate better. I just I feel better. I'm not putting on as much weight as fast than when I don't do it. So yeah, I definitely have a lot of benefits from it.
You don't eat anything after 3 p.m.?
No. I don't eat till 3 p.m. In that I tend to eat between 3 and 9 p.m. I don't have breakfast. I typically don't have lunch unless it's a business lunch. I am going to lunch tomorrow and the next day, so I'll eat earlier, about 12:30 to tomorrow and Friday. But generally, I don't eat till after 3 in the afternoon.
Interesting.
And then
Yeah, there's both sides to that. Some say eat all your calories earlier in the day and don't eat after 6 p.m. and yada, yada, yada. So there's all kinds of.
I find that very difficult. I think I would be in Gary's camp, that I would be the added stress and the torture of not eating after 6. I think would be for whatever reason, when I don't eat, I don't get that hungry. But once I start eating, I tend to be hungry. So having to eat in the morning and then have to stop and not go to sleep or whatever, I think that would be torture for me.
Yeah, everybody's different.
Yeah. That's for sure.
Rick's got his hand up.
Yeah, I see that. What can we do for you, sir?
So I'm just looking at this methionine because it's not something I've heard of, and it's more complicated than it looks, as usual, because methionine, less methionine is a good thing. Methionine. Hold on a minute. Let me, because this is complicated, and I want to get it the right way round.
Sounds like an essential amino, is it not?
methionine restriction, so less methionine, it encourages apoptosis, which is cell death in human prostate cancer cells. So less methionine is good. However, methionine has a cousin called SAM. SAM stands for S-adenosyl methionine.
Oh boy.
And adenosyl methionine is good. So the more adenosyl methionine you have, it can inhibit prostate cancer cell growth. So all I'm saying is, it ain't exactly clear. We have to be looking at SAM, methionine, and prostate cancer all together.
Well, where do you get this SAM stuff? We know the other stuff's in fish. Where's this? Where's the cousin?
I don't know. I was just looking at that when you called my name.
Yes. It's in a raccoon that I gotta.
But by the way, tofu has less methionine than fish does. So you're looking for a protein source that doesn't have a lot. Tofu,
Chris,
considerably
that's
less.
Just tasty. That tofu stuff.
Just
is
not to beat
that is so
not to beat a dead horse on the methionine, but if you look at a methionine chart of all foods, meat, animal protein is super high in methionine. That's why to me sometimes it's what you're not eating. If you replace a steak with the tofu, like Ray said, then that's probably more prostate healthy. But again, you gotta like that. But it's not just fish. There's a lot of foods that are high in methionine.
Okay. Well, who knew? But I'm still trying to find out exactly where SAM, where you get your SAM from.
That would be good. Well, I think while you go hunting, we're going to go down to. Does anybody else have anything before Joe came up? Joe Mingrone about he went to a BPH doctor, which is if you read the statistics, if you get old enough, besides the prospects of having some type of prostate cancer, for most people having it and not knowing it, which is good for their whole lives. BPH is going to creep in and affect your life somewhat. You guys are way younger than me, so it most probably hasn't gotten there yet. But and Rick told us we're the BPH guys. The AS group basically is in charge of the BPH, so it is in our wheelhouse. So without further ado, Joe, tell somebody what a brief description of what that particular treatment process is and what you thought about it.
Well, I've been having BPH symptoms for many years, and I have a large prostate. Just some background, over 100 cc prostate, and having there's a score test called the IPSS, which I rate relatively high, and it goes up to 30, and I've been 25, 26. It's just a questionnaire type of test on your LUTs, your lower urinary tract symptoms. They call them LUTs. So anyway, I also have grade group 2 prostate cancer. So I've been seeking treatments that are kind of won't affect the prostate cancer in the sense that make it more difficult to monitor, and like some of the procedures, such as you can't get MRIs, or MRIs are hard to read afterwards, such as I forgot what it's called, the Urolift type thing where they put stitches in and they're metal. So, you have all those. So I was looking for something kind of friendly. And also, if I have to get treatment, it would be preferable not to have a large prostate, because radiation is kind of induces these urinary symptoms or make them worse, the ones that I have already. So I've been taking the medications, both the Flomax and the finasteride for first the Flomax, and then now the finasteride in the last couple of years. And And really, I don't find them terrible. I'm getting kind of fed up with the BPH stuff. So I went to a doctor and asked for, some suggestions on treatments. Well, I read up on it and I looked at that Holib sound like a good one. The Holib's a Holium laser treatment. So what they do is they go through your urethra with a laser. They hollow out your whole interior of your prostate. They almost describe it as taking everything but the skin off of an orange. You're hollowing out the interior. They cut it up into pieces and extract it, and they're able to biopsy it, which is another advantage in the sense that some of these laser treatments just vaporize or they just kill the tissue. And it's not you can't get a biopsy on it. So I discussed this with I live in, although I'm a U.S. citizen, I live in Canada and Victoria, and I was kind of wondering what options they were. And apparently that option is open. They have two guys who do it in my area, Victoria, Vancouver area, and one happens to be right on my island in Victoria. So I spoke with him last week, and he thought I was a good candidate because with with prostates over like 80. Many of the BPH techniques aren't Urolift and all those. They don't, maybe not Urolift. The ones that use Resume is not. I don't have them at the tip of my tongue, but the other treatments aren't really applicable to large prostates or harder to do. But so I talked, the guy was quite young, so I was kind of like worried about how many he's done of these Urolifts, but he had training at UCSF, which is a good thing, I think. And he seems like he's under 30 years old, the doctor. So I was, maybe it's just me, but I don't know his age. But I asked him how many, and he said he's done 100 or so, he does 100 a year. So, but I kind of backed off and didn't want to ask him how many years, he's been doing them, but he said he does 100 a year, maybe for 2 years or something, and he's had very good success. So the advantages of it is there's very low, it's a fast recovery because it's laser, you don't bleed much, and you don't need no transfusions. There's no incision because, it goes through the penis, and there's no, it has a fast healing time. You can, as a matter of fact, he sends people home right after the surgery, which I said, is there an option to stay overnight? And he goes, yeah, you can stay overnight. But the catheter doesn't come out for 24 hours. And then the catheter's out in 24 hours. And it's pretty, and also on the two symptoms, on, the two known side effects, of all these kind of prostate surgeries, which are ED and incontinence. It's very low. It's like 1%. He goes, we don't go near the neurovascular bundle, and because they keep the skin on, they don't really. So it sounded good. I don't know if it was oversell. I did ask him about. There's another type of kind of non-invasive. I mean, this is quite invasive, and it's even more. They take more tissue than a typical TURP, which used to be the gold standard in this kind of thing, where they kind of hollow out around your urethra with a cauterization kind of tool. I don't know what you call it, but some tool to hollow out around the urethra and to get it to expand it. And it's also it's as durable as a TURP, or even more so, and so you don't have to have it done. So I asked him about a different other treatments that I read about, but I don't think they're offered locally, like PAE, which is where they block some of the blood vessels to your prostate, and it shrinks it. And it's a very non-invasive in the sense that they just go through your arteries with the catheter through, and they put some little beads in, and they plug up blood vessels, and it kind of chokes off the prostate from getting much blood supply. And so that one seemed also kind of attractive, but he thought it wasn't as very durable. Like, goes, if you want to do it every 2 or 3 years or something, I don't know. But it's not what I read. It was, I never heard that critique, but he was kind of pushing, of course, what he does, the pull-up. So anyway, that's my story. I don't know if any questions. So I'll be happy to ask if anybody has it. He's
Joe,
done
I
very
just
big
have a
prostates too. I said, "What's the biggest prostate you've done?" He said, 400 cc's. I can't
Wow.
even imagine that.
Wow, that's crazy.
That's like an orange, more,
yeah.
more. So if anybody
Joe,
has any,
yeah, Joe,
Watch
I'll tell you, my father-in-law had that surgery at age 90. He had the whole-up laser, and his
oh,
was a 300 cc prostate.
wow,
And with him, it worked. It was my wife saw his doctor, and he said, "How many 90-year-olds have you done this on?" And his expertise was large prostates. There was another guy who did medium, but his was the large. And he said three. And my wife said, "What happened?" He said, "One died on the table." These are 90-year-olds that he did it on. One's having major complications, and one's doing great. So my father-in-law just doubled his success rate on the on it, and he's going to be 92 in
wow.
a month or so.
Good for him.
So it was good. And the other thing I would too is look into something called aqua ablation, which is where they use. I don't know if you've looked into that at all. I have a friend of mine that had that, and it seems to have worked, but I don't believe he had any type of prostate cancer, so I don't know if that's available, but that worked
And
where
I,
I guess they
Have to
use like a
resume.
water
it
to
looked
treat.
like the like Resume uses steam, and then Aqua, I think, just hot water instead to kill the tissue. Yeah, I've heard.
So guys, I'm gonna jump in because Jose's here too, and Jose and I and Dr. Mark and Gary and Gary and Hugh and Eric were included, I think, in this, but they didn't respond. Um, we've been talking about presentations, and Jose has a extended family member who happens to be the rep for aquablation, and Jose kindly said to us, "Well, she can come on and give a presentation." Our problem is that we don't like to do branded promotions for exactly the reason that you're hearing right now. There are different options. It could be Resume, it could be Urolift, it could be aquablation, etc., etc., etc. And if we have one person come on, unless they review everything, it's not fair. And we don't want to have that bias. Now, we did do a presentation a couple of years ago with Dr. Steve Kaplan out of Mount Sinai, and that was a great presentation. I'll put it in the chat window again in a second. It's not the BPH your grandfather had, I think it was called. I'll let Jose speak for himself, but we did say to Jose, look, if they have a medical director and they want to come on and wants to present all the options, yeah, we'd be happy to do it. So that's where the problem is. We need be happy to do another one of these presentations, but we need somebody who's going to present all the options. Senor Jose.
I'm here. I'm here. I'm listening, and I'm going to
Yes, and
speak.
let's just excuse Eric and give Solo Arts Heal tonight a plug because he's
Yes.
going off to help with Solo Arts Heal. Thank you very much.
Yes.
And Alan, I hope you show up for the because you have rescue dogs in the family. Oh, come on. Okay, go on.
I'm also going to plug the Solo Arts Heal because I am responsible for John to bringing him in.
Yes.
And I think that you'll enjoy him. He's a great guy, and he does so much, not only with the animal world, but teaching, and also working with women in recovery and people with autism and all that kind of thing. Plus, he was a menswear fashion designer in New York City. As far as the ablation, it was really, she is not a sales rep. She is actually in the rooms with the doctors.
Oh.
showing them, and she can speak about the whole process. She is not the person selling it. She is trained to be there with the doctors. And I will ask her for the clinical trial that had been out so that we can share that, privately or whatever. And in New York, it's being done a lot. This Dr. Kelly that I asked you about, Rick, supposedly he does 7 or 8 of those a day. And she's got her list of people that she says, I would go to this one, I would not go to that one, and things like that. So she is, she's not a medical, she's not a doctor, but she is very involved in that world. So, but
Jose, is this the aqua ablation? Is that what
yes,
we're talking about?
yes. And she travels all over New York area, even Indiana, to train sort of these doctors. She works for the equipment company that makes the equipment for the aqua ablation.
Okay.
But she works on the training side, not the selling part. She's not a salesperson. So anyway, I thought it's good information. It doesn't hurt to. There are new things out there, and that's it.
Like kind of Rick, what Rick said, if she's willing to explore or just briefly describe the major players that are out there, the Eurolift, the Resume. I'm not really familiar with some of them because statistics prove, because I'm having a little bit of a problem myself, that this is going to happen sooner or later in some way, shape, or form. Hopefully, way down the road for you guys or whatever. And since we're the the BPH guys, if she could, I read that Dr. Dr. Perlo didn't like it. He thought it was all one sided. But if she could expose, well, in Eurolift they do this, and in this one they do that, and then point out what her equipment and her company does. My personal opinion, I got no problem with that. I think we should expose everybody to the whole world out there. I know that Scott Colcord was in touch, I think, with Joe about he had this hole up, and he swears by it. It worked out really good for him, and he's a cranky kind of guy. He's about 76 or 78, something like that, and he seemed to be real happy with it. And one other note before we go further, if anybody doesn't know, all those books behind Joe are real. That's not wallpaper. The man likes to read. I just, because if he could show his whole room, you're going to see all them books on the wall, and I thought it was wallpaper. But he told me that I saw the real deal. They're all books.
So let me just say, we just have to be real. We have to be real careful if it's coming from one of the presenters. It just has to be a fair and balanced presentation. If they can do that, they can give us a fair and balanced presentation. It's fine. If it's going to be angled towards why aquablation is better than this one or that one or the other one, it ain't going to work for us. But just say it.
I haven't seen her since my emails to you, and
okay.
I'm happy to speak to her. And it doesn't have to be her. It could be, like you said, the different sides of ablation or TERP or whatever. But just to inform people what it is and what it's gaining more and more use. But I'm not committed to anything. I'm not getting paid for this. I thought
I understand.
It fell into my lap. She showed up, and I'm like, what, you do what?
Jose,
I guess so.
Jose, I get it. It's just that we don't do branded.
No. I'm not.
Okay.
That.
Now
I'm totally fine.
Okay.
I'm gonna go to Sal.
Now look, how much have you got left? Because there are people who think that maybe we could even finish this meeting at in 95 minutes tonight. That would be something special.
Yeah, we covered everything. Unless anybody has anything, we can go.
Okay.
Going to meet my people. I will see you next week.
Okay, I'll see you, Jose, a little later. I will be there. Don't worry.
Okay. Thank
Okay,
you.
come to Solo
Alan,
RTO. Goodbye,
Alan, see you
everybody.
there. And
All righty,
Stuart,
everybody,
Alan
have a
and
good
Stuart,
evening.
you both will be there.
Stuart, you got no chance with Alan. He'll be
Sorry, I'll be asleep.
okay.
Stuart said he
All
would
right.
try.
Okay.
Yeah.
Good.
Night all.
Good,
Thank you,
good
gentlemen.
night, everybody.
Rick and oh,
Yes.
I will not be around for the next 7 weeks.
7 weeks.
7 weeks.
But you don't have to tell me.
No,
Don't
I'm
tell
telling
me.
Gary.
Oh, you're telling Gary and Hugh. Make
Yeah.
sure you tell Hugh as well.
Yeah. No, I'll send an email. Yeah,
Yes.
we're
You're going to
leaving.
Japan, right, Phil?
We're leaving. We're going to Australia. My brother lives in Australia. My daughter is joining us there, and we are going with her and her partner to New Zealand for a little over 2 weeks, back to Australia, and then my wife and I are going to Japan. So we're going to be gone
Excellent.
for 7 weeks.
Well, have a wonderful time. Safe travels. That sounds fabulous.
Yeah, it should be a good time. Hopefully, we'll get good weather.
Now,
So,
where are you going to? Where in Australia are going? All over or where?
no. Just no. We've been a few times. We're just. My brother lives in Sydney, so and I haven't
Oh,
seen him in about 5 years. So we're going to see him and his family for
okay.
4 or 5 days.
Okay, but it's getting cold there. It's you
Yeah,
get you know.
yeah. But then we'll have good weather in Japan. Japan will be like summer.
Okay, okay. Well, that's good.
It
We've
just
got
got
a couple of Ancanners. I have a good friend who I was at school with, who lives in Sydney, and then we've got an Ancanner in Melbourne who attends a bunch of our groups.
That's great. Yeah. No, you know what? At our peer support group, we had this guy from Australia who'd come on to our Zoom meetings. It was like incredible.
Yeah, we have that. We have that with Steve.
Yeah.
He comes on. Steve Cavill comes on to our Men Speaking Freely, and he comes on to the under 60s group and a whole bunch of things. Look, well, we're keeping Tosca here. Goodbye,
Yeah.
Tosca. Bye.
Take
All
care,
righty.
guys.
Take care. We'll see ya.
Hey, Tosca, we
Yes.
had a newbie come in yesterday to the advanced group, 61 years old. He lives in your town in
Does he
Melbourne.
really?
Yes, nice, very nice fellow. His name is John Graff. Very nice fella. But right now he's in the middle of treatment at Moffat.
Okay.
He's got a 13-year-old, and that's really concerning him. How does he talk to his kid about cancer? It's tough. Anyway, at some point, I'll connect you. He sounds like a very, very, very nice fellow. He
Yeah.
lives in Melbourne Beach.
Yeah. I'd like to get together with him. That's 15, 20 minutes away. No problem
Okay,
at all.
did you now let me ask you, did you go to Vet Speaking Freely last night or not?
No, I did not.
Oh, you
I did
didn't.
not.
Okay.
I did not have the opportunity.
All right, that's okay. I was going to ask you how it was if you went, because I
just got back from we were away for 12 days and 11 days in New Jersey, and it was just
okay. No worries. I thought if you went, they had 14 people.
nice, good,
So and I heard it was quite good.
excellent, wonderful.
So
all right, well, we're off next week.
yes.
The one thing that we did not have tonight was the official disclaimer. We recorded tonight. I hope somebody stopped the recording. I didn't